Good evening, dear doctors. Today we are going to conduct another great clinical episode on our XP Connect webinar education series, powered by Versana Technology from G Healthcare. Today we have a pioneer in the field of diagnostic ultrasound and fetal medicine. Please welcome Dr. PK Srivastava, Director Yashdeep Ultrasound Center, and he is ex-professor Radiodiagnosis, KGMU, Lucknow. Dr. Srivastava has successfully authored 7 books on ultrasound imaging. He is the chairman, Ultrasound Education and Research Foundation. He is ex-president IRA-UP branch and ex-president IFUMB and has held many such respectable positions in various societies. Dr. PK Srivastava is the recipient of several prestigious awards, including Excellence in Teaching from MLBMC, Award of Excellence 2014 KGMU, Sir J.C. Bose Oration, and many more. Before we get started, due to nationwide lockdown, there has been a huge traffic load on internet services. If you experience temporary interruption in transmission, kindly bear with us. We will sort it out immediately and resume. Kindly do not log out and keep refreshing the screen every 30 seconds. Now I welcome Sir to address our views with his clinical talk on ultrasound in obstetrical emergencies. Thank you. Over to you, sir.
Good evening, Zenith and the entire G Education team. It is indeed my pleasure and honor to have this education program, and I am thankful to GE for inviting me for this educational webinar series. In the hard time of this unexpected lockdown condition in entire world, it is the best way to teach the pupil and share the experience by these webinars, which are highly educative. So today I am going to talk something very relevant about the role of ultrasound in obstetrical emergencies. We know that ultrasound is first and the primary tool for evaluation of pregnancy. It is also known as the third eye as far as the pregnancy is concerned. Ultrasound is not only to look for the pregnancy or see the development of the fetus, but it has got the vast role as for the emergency situations which are unexpected at times in obstetrical situations, which requires immediate action by the clinician to save the baby as well as the mother. Ultrasound obstetrical emergencies not in the and can happen in any time during the course of pregnancy, and ultrasound plays a major role in every trimester of the pregnancy. The role changes, but the importance of ultrasound is always there, how to deal in this emergency situations. So emergency situation can happen in first trimester, it can happen in second trimester, and it can happen in third trimester. So I am going to deal the importance of ultrasound as far as the pregnancy is concerned, its role in first trimester emergency, and its role in second trimester emergency, and its role in third trimester emergency. The first trimester emergency, it is the most important situation to see whether the pregnancy is normal, it is growing normally, or there is some emergency situation. The most common in first trimester emergency is ectopic pregnancy. The ectopic pregnancy is the leading cause of mortality in first trimester of on morbidity. It accounts about 9 to 14%. The unfortunate part is that 50% of ectopic pregnancies are asymptomatic. Patient does not have any complaint, and then suddenly there is a emergency situation with acute rupture of the ectopic, and which was not clinically or symptomatically suspected. The other things which are in first trimester emergency where ultrasound plays a major role is antepartum hemorrhage, complications of abortions, foreign bodies, and all those things. But the biggest group is ectopic pregnancy. The risk factor for the ectopic pregnancy is the history of previous ectopic pregnancy in the patient, tubal surgery, pelvic inflammatory disease. The most important thing is the early diagnosis for the proper management in these situations so that the catastrophic situations can be avoided and avoided. If clinically, one always take the history of previous tubal pregnancy or previous ectopic or PID. Biochemical screening is also very, very important as for the ultrasound correlation. A beta HCG plateau in early pregnancy is highly suggestive of ectopic pregnancy. TVS is very, very important transvaginal ultrasound when beta HCG level is around 2000 ml per unit, then one must see the gestational sac on transvaginal ultrasound. On transabdominal ultrasound, beta HCG level when it is equal to 6500 ml per unit, one should see the gestational sac in the uterus. So these are the things one should keep in mind as one dealing with the ectopic pregnancy. In the first trimester ectopic pregnancy, the location is very, very important. It is seen that about 93 to 97% the location is in the fallopian tube. And in fallopian tube, there are different parts of the fallopian tube where it is seen in ampullary, it is the most common, and 70% of the tubal pregnancies are seen in ampullary part. 65% of all ectopic are seen in the tubal part like this. This green circle is the biggest one, and that comprises about 65% of the ectopic pregnancies. 12% pregnancies are seen in the isthmus. Femoral accounts for 11% of the tubal pregnancies, and interstitial pregnancies are there, which account for 3 to 4%. Ovarian pregnancy accounts for 0.5 to 1%. These are the extra uterine. But we can also get uterine ectopics like scar pregnancy, which is rare, less than 1, which is rare, and the cervical pregnancy, which is also not that common and account for for less than 1%. And besides that, tubes, uterus, scar or cervix, there may be an abdominal pregnancy which account for 1 to 4%. So one should keep in mind what they are dealing and where, and it is very, very important to locate the site of implantation in ectopic pregnancy for the proper management of the pregnancy. This is the case where the patient did not have any complaint, came for the routine checkup for ultrasound in the pregnancy checkup, and when I did ultrasound, I found there is a pregnancy seen in the right adnexa, and there is a fluid seen inside the ovarian fossa and adnexal region, and there is an embryo, and when you can see this, there is a ring of fire which is seen around this sac, and there is a live embryo which is showing the cardiac pulsation. This is a silent rupture impending rupture of ectopic. The patient did not have any much pain, not much symptoms, but ultrasound immediately picked up this is not a normal situation. There is a live ectopic, there is a ring of fire, a live embryo, and there is a fluid. And this fluid is very, very important to understand because this is the clinical sign which immediately says it is the impending rupture. And the patient was immediately taken to the OT, managed, and the emergency situation was avoided. Again, this is again a case where there was a silent impending rupture in the right ovarian fossa, where you can see a echogenic sac. There is embryo in the sac. On color flow imaging, there is a high vascularity seen around the sac. It's a ring of fire, and once you see the video, you can see it's a live embryo. And again, there is a small collection which is seen in the ovarian fossa, and again this is a case of impending rupture, silent rupture of the ectopic. Again, when we see the adnexal ovary masses, one should look, and there is a history of missing period, look for the pregnancy, and if the uterine cavity is not there, serum beta Hcg is there, then this is the adnexal mass in the right ovarian fossa, and this is a live embryo. This is the omni view which shows you this is the corpus luteal cyst. This is nothing but this is the corpus luteal cyst which has come out very beautifully on omni view, and this is the embryo, gestational sac, and this is the embryo. And once you see it, you could color Doppler, you can see the live embryo which is coming there. So 3D is very important tool to see the location. Ovarian pregnancy or adnexal pregnancy are difficult to be separated from ovaries, and again you can see here they look like adnexal mass, ovaries adherent, and it is difficult to separate from the sac from the ovary. This is again a adnexal ovarian pregnancy on the right side, where you can see a live embryo which is seen there, and this is the same case where you can see the marked vascular ring which is seen around this sac, and there is a live embryo which is seen there, but there is no fluid seen in this around this, so there is no sign of impending rupture. But tubal pregnancies, they can grow up to 8 weeks, and once, because caliber of the tube cannot take more than 8 weeks size of the pregnancy, and once it is more than around 8 weeks, the tube will rupture. So this is very important to understand what is the size of the pregnancy, and that how it is important to look for the things. And why it's not going. Again, this is a very interesting case. A lady, 40 years lady, who came with the acute pain, and there is a marked pain and there is a bleeding. When I did ultrasound, I found the uterus was absolutely fine. You can see here, but there are multiple vesicles which are seen in the pelvis, in the pouch of Douglas. They are floating. You can see here multiple thin-walled vesicles which are seen floating there. And then on color Doppler, you can see marked increased flow in the vesicle and in the vessels. And there is a mass which is there in the left adnexa, and multiple vesicles are seen there. Then this is the peroperative case, and this is a very rare case where we found a molar pregnancy in left ovary, ruptured molar pregnancy in the left ovary, this is the uterus, this is the right ovary, this was the mass which was there, these are the vesicles, and this is the ruptured molar pregnancy in the left ovary, and this is a very, very rare case. Again, not only that, at times you find heterotropic pregnancy. The heterotropic pregnancy incidence has gone high because of the IVF treatment, and ultrasound is very, very easy and very important tool to find out. Here you can see this is the uterus where we find a uterine pregnancy. There is a adnexal mass in the right adnexa, and there is a sac and there is an embryo. This is the omni view, which shows you this is the uterus, this is the embryo in the uterus, endometrial cavity, but this is the adnexal tubal pregnancy, and this is the video which shows you the both embryo are live. This is the adnexal, right adnexal tubal pregnancy, and this is the uterine pregnancy. The patient was managed. This tubal pregnancy was taken, adnexal pregnancy was taken care of, and then the uterine pregnancy was allowed to continue and grown, and the lady delivered a normal baby. Coming to the other things where we find the different type of pregnancies, which you can see here, the ectopic pregnancies like gestational sac, which is seen in the interstitial part of the right fallopian tube, which is seen here. Ectopic pregnancy in the rudimentary horn of the unicornuate uterus, which is seen there, where this horn is not communicating with the endometrial cavity. The C is the ectopic pregnancy in the rudimentary horn of the connecting with the endometrial cavity. Here you can see the connection of the sac with the endometrial cavity. D is the pregnancy is in the right horn of the bicornuate uterus, or it is intrauterine pregnancy. You can see this. E is the pregnancy in the right horn of the septate uterus, which is seen there, and F is the in the lateral angle of the endometrial cavity, or angular pregnancy, intrauterine pregnancy. Whereas A, B, and C, they are the ectopic pregnancies, but D, E, and F, they are abnormal intrauterine pregnancy, and that is very, very important to understand that. The cornual pregnancy is the cornual is actually a misnomer term. Actually, it's the uterine, but it is seen at the lateral side or cornu side of the pregnancy uterus. The 5 different types of the ectopic pregnancies which are seen outside the endometrium. Here 3 are this endometrial and 2 are intrauterine, which are eccentrically placed gestational sac causing mass effect termed as the cornual pregnancy. Cornual pregnancy in the bicornuate or septate uterus. Interstitial ectopic pregnancy in the interstitial part of the tube. Pregnancy in the rudimentary horn of the unicornuate uterus. Intrauterine pregnancy. Pregnancy in the cornu or the horn of the bicornuate uterus. Pregnancy in the cornu or a horn of the septate uterus. Angular pregnancy in the lateral angle of the endometrial cavity near the ostium of the fallopian tube. And this is the picture which shows you a bicornuate uterus. One cornu is this, another cornu is this. This right cornu is showing you a pregnancy, a gestational sac, and the embryo. So this is the cornual pregnancy which is seen there. How it is very, very important to understand the location, because the cornual pregnancies are very, very dangerous because there is a rupture of the muscle or myometrium once they can grow up to 12 to 16 weeks. So here this is the case. This is the 2D image which shows you a small gestational sac which is seen there, and it is covered by myometrium. This is the sac rim, and this is the 3D coronal view which shows you beautifully the left side cornu is this, and this is the right cornual, and this is the right cornu, and this is the sac, and this is the embryo, and this is the volume contrast imaging of the same patient which highlights the sac very beautifully as we see in MRI what we see on ultrasound on the volume contrast imaging. So this is very important. The cornual pregnancy in the rudimentary horn in the banana-shaped unicornuate uterus is very, very important to understand. This rudimentary horn, not communicating with endometrial cavity, can grow and rupture in second trimester. And there is a rupture, of the myometrium. This gestational sac surrounded by myometrium, and it may look like an adnexal mass. 3D ultrasound is choice of investigation because 2D is not going to show you the coronal image and the thickness of the myometrium. And here is the case which you show you. This is the unicornuate uterus, and here you can see the gestational sac which is seen here, and this is the endometrium which is going there, and this is the image which is showing you. This is very, very important because once it ruptures, it can go up to 12 weeks, and once it's ruptured, there is a catastrophic bleeding due to the myometrial rupture. The cornual pregnancy in the bicornuate uterus, if it is in the right position, it can grow as a normal pregnancy. But if the sac is eccentric, then it is a ectopic, and it may grow up to 16 weeks, and then there is a rupture. And here you can see this is the bicornuate uterus. This is the one cornu which is seen there. This is the another cornu, and this is the pregnancy which is seen there on 3D imaging. This is the embryo. Here you can see this is the embryo which is around 7 weeks 5 days, and there is a thick rim of myometrium seen around this sac, this echogenic sac. There is no endometrial communication there, and this is a thick myometrium, and this is very, very bad sign because it can grow, then will be a rupture of the myometrium. So this is very, very important to understand, and you can guide the clinician what is to be done. Again, you can see a bicornuate uterus with a cornual pregnancy. This is the embryo which is seen there in 2D, and this is the 3D. I have to sweep a wide angle to connect both the cornu. This is the left cornu which shows a thick endometrium. This is the right cornu, and this is the omni view with a wide angle, and this is the embryo, and this is the left one, and this is the right one which is seen beautifully on 3D omni view, and seeing the exact size of the embryo. And thus then coming to the cornual pregnancy in septate uterus. And septate uterus, intrauterine pregnancy, 55% of the uterine anomalies. 3D shows the normal fundus with no indentation. Septum may be partial or complete, may extend into the cervix. If gestational sac is eccentric, crucial to see the contour of the fundus with 3D ultrasound in coronal view. And this is a thick septum which is seen going down up to the lower 1/3 part of the uterus. This is the left, this is the right, and here is the gestational sac which is seen here. Here lying the ovary in a septate uterus. You can see beautifully the gestational sac in septate uterus. This is the 3D tomographic ultrasound cut showing you the same case. This is the thick septum which is coming there. This is the right side of the uterus. This is the left side of the uterus, and here is the gestational sac. You can see beautifully. This is the embryo inside. Again, this is a 6 weeks 5 days embryo, and this is a thick septum which is going down, dividing the subseptate uterus. This is the left, this is the right, and this is the pregnancy seen in the right side of the septate uterus in the cornu of the septate uterus. The interstitial pregnancy, 2 to 4% of the ectopic pregnancy, eccentric in location. Implantation causing a bulge in the superior lateral fundus margin of the uterus, can grow up to 12 weeks. Rupture lead to the massive fetal hemorrhage. This is very important to understand. Ultrasound can show you a thin myometrial band less than 5 mm around the gestational sac and a separate empty cavity. The interstitial line sign an echogenic line from the lateral corner of the endometrium to the ectopic pregnancy and positive ring of fire. and this is the uterus. This is the eccentric location of the gestational sac, and if you see this line, this is the endometrial interstitial line. This is line, and this is very, very important to understand that this line which is seen there is the endometrial interstitial line, and this is the thick rim of myometrium. You can see here, this is the myometrium which is in interstitial pregnancy. Again, you can see interstitial pregnancy. Once you see eccentric location of the gestational sac, you always suspect interstitial pregnancy. This is the 2D which shows you the eccentric location of sac. This is the Doppler which is not showing too much of flow, and this is the 3D omni view, and 3D omni view shows you this is the gestational sac which is seen there in the interstitial part, and this is the sac which is seen this beautifully in omni view in interstitial pregnancy. The angular pregnancy is actually it is seen just near the ostium of the tube, at the lateral angle of the uterine cavity, at the superior lateral angle of the endometrial cavity. Eccentric gestational sac, ultrasound gestational sac, a broad interface with the endometrial echoes, educate myometrium covering around the sac, but no intervening myometrium between the endometrial cavity and the gestational sac. Uterine rupture happens in 23.5 to 25% of the cases. But this you can see beautifully on 3D. What you have seen beautifully, this is the endometrium, this is the angular part of the endometrium, and this is the gestational sac. But there is no intervening myometrium between the endometrium and the sac, what we seen in interstitial pregnancy and the cornual pregnancy. This is the 3D omni view, this is the endometrium. This is the lateral angle part of the endometrium, and there is a sac. This I could diagnose only because of the 3D, because I found only on 2D an eccentric gestational sac. So this angular pregnancy is again very important to understand, because there is a high incidence of rupture in this, and the management is accordingly done. The scar pregnancy is not that common, but the previous history of C-section or repeated intervention in the uterus may lead to the scar pregnancy. The intrauterine pregnancy may grow to the normal size. However, if the eccentric location, it may rupture. There are 4 types of the scar pregnancy based on ultrasound findings. One is gestational sac embedded in the less than 1/2 thickness of the lower anterior corpus. Grade 2 is gestational sac extending to the more than 50% thickness of the myometrium. Grade 3 gestational sac comes out of the caesarean scar, and grade 4 gestational sac looks like tumor with increased vascularity. Incidence is 1 to 100 to 1 to 2,500, and here you can see a scar pregnancy which is seen there in the anterior part of the scar. This is the 3D view, omni view, which shows you the embryonic node, and this is the yolk sac which is seen there. How we can grade it? If you see this diagrammatic representation, this is the endometrium, this is the grade 1, and we see a scar pregnancy where the gestational sac is just seen adherent with this scar, and it is just confined within the 50% of the corpus or the myometrium, and this is the ultrasound picture which shows you sac. It is there, but it is a grade 1. In grade 2, the gestational sac extending to the more than 50% of the thickness of the myometrium, and this is the thick rim which is seen there, and this is the sac, and more than 50% of myometrium is invaded by this gestational sac in the scar pregnancy. Grade 3, when gestational sac comes out or just bulging toward the caesarean scar, and this is the case where it is bulging out from the scar, and this is the big embryo. It's around 8 weeks of size, which is seen there, and grade 4 when there is a rupture and there is a tumor-like mass is formed, and this is the uterus, this is the scar, and this is the mass which is seen there. Patient came with his history of marked pain, bleeding, acute tenderness, and this is the uterus, and this is the mass. This is the grade 4 scar pregnancy. Again, you can see the scar pregnancy where we can see increased flow around the scar, which is seen there. And you can see here, this is the scar, this is this, and this is the 3D omni view. And then you can see a live scar pregnancy where the scar is the pregnancy in the scar. Live embryo is seen on color Doppler. We can see the cardiac pulsations. This is a 3D, and this is the peroperative. This is the peroperative finding of the same patient. This is the uterus, this is the fundus, here is the scar pregnancy, and this is the tadpole embryo. Can you see? It looks like a tadpole. This is the crown, and this is the rump. And here you can see the crown, and these two things which are black spots are the evolving eyes. Can you see beautifully? And this is the peroperative finding of the scar pregnancy, beautifully picked up on ultrasound and properly managed on timely intervention. The cervical pregnancy, you can see again ectopic location of the gestational sac in the lower part of the uterus. This is the 2D which shows you this is the sac in the endocervical canal. You can see there, and this is the 3D omni view which shows you beautifully the hourglass shaped dilated endocervical canal. Here is the yolk sac, and there is an embryo. So all this thing, what we can see here on 2D is beautifully demarcated on 3D omni view, and this is done. Again, we can see another case of cervical pregnancy. Where we can see this is the 2D which shows you the dilated endocervical canal. There is a gestational sac. This is the yolk sac, and this is the embryo, and there is a 3D omni view. This is the fundus. This is the endocervical junction. This is the dilated endocervical canal, and here is the distal part of the cervix. And you can see the sac, you can see the embryo, you can see the yolk sac, and this is the 3D of the same where we can see beautifully the embryo. The question is this: cervical pregnancy, how you should see and how you can differentiate pregnancy from the lower uterine segment pregnancy. And this is the case where we can see the implantation of gestational sac in the lower uterine segment. This is the fundus. Once you measure it, the thickness of the fundus, distance of the fundus to the lower uterine segment, this is the fundus, this is the 3D, and this is, and here comes the cervix. So this is the lower uterine segment pregnancy. This was an IVF conceived patient, had one abortion in first IVF, in second IVF. So we kept on seeing it and measuring the things. Ultimately, this and lower segment pregnancy start growing up, and then this is the fetus, and this is the uterus, and then it started growing up, and now it is around 28 weeks of pregnancy and continuing. So that is the way how we manage, how you have to see measurement, distance, size of the embryo, size of the yolk sac, size of the amniotic cavity, where it is going towards the cervix or it is going towards the fundus. So all these things, ultrasound plays a major role in assessing and as far the outcome of the pregnancy. This patient came with the history of acute pain, with severe pain and with the tossing on the bed. And when I did ultrasound, I found a cervical pregnancy there. But this was not the cause of the pain. The cause of the pain was acute ovarian hemorrhage. And this is the enlarged ovary. left ovary, echogenic collection which is seen in the ovary, and this is the white echogenic collection is nothing but this is a fresh blood. This is the torsion and acute hemorrhage, and this is the Doppler which shows your twisting of the vessel. So this was the case. So ultrasound not only decide about the things whether it's for the pregnancy or there is something wrong with the other things. So this was the ovarian hemorrhage with fresh hemorrhage which is seen. Fresh hemorrhage in ultrasound anywhere in the body is always echogenic, whether it is eye, whether it is in the liver, whether it is in the kidney, whether it is ovary, anywhere it is always echogenic. Coming to this is a very interesting case. Why I tell you that talking to the patient, taking the history, taking the details and how this is something I don't know how many of you have ever heard it. Fetus in urinary bladder. This patient had dysuria, bleeding PV, pain, fever off and on, went to the urologist many times. Every time they prescribed antibiotics, culture, infection, antibiotics. Then she got a CT done, and the CT is there, and they saw there is a vesical calculus. The patient was referred to me. I did ultrasound, and I also thought it is a vesical calculus. But then I said I am not convinced, it's not looking like in the calculus. Then I saw this, and then I thought, oh my God, this may be a fetus. I did a 3D, and immediately I got whole fetus which is there. It is seen there. This is the crown. This is the rump. These are the limb buds. Can you see beautifully? This is the crown. These are the limb buds. Then I took the history, and the history was very interesting and very good. The patient had got the pregnancy about 4 or 5 months back. He had the pregnancy about 8 to 12 weeks, 10 weeks. She underwent an MTP, and after MTP she had severe pain and bleeding, and then she was managed conservatively, and after that she started having dysuria, fever, infection, and every time she was managed on the lines of UTI. Actually, this was while doing the MTP, this was actually utrovesical fistula. And utrovesical fistula, then this fetus came to the urinary bladder, and which was diagnosed as a stone, but actually this was a fetus, and this is and then this is something. So history is very important to understand. Talking to the patient, taking the history, managing the patient accordingly, and ultrasound, and then if you got the proper gadget, you can see beautifully the limbs, the crown, and everything. And this was a fetus in UV because of the MTP, utrovesical fistula, taking the fetus to the urinary bladder. Pregnancy with heavy bleeding and acute pain came, and this was a large uterus in the first trimester. There is a hemorrhage in the uterine cavity, and there is a big mass which is seen, and this turned out to be a big molar pregnancy, unusual molar pregnancy which is seen on ultrasound. Again, this is a patient who had first trimester pregnancy, then started having bleeding. Somebody tried to intervene, and after that she collapsed and had severe bleeding. He came to further evaluation. This is the uterus. There is a big low-level echo-complex mass. As I put the color, there is a gushing of the blood seen in the mass, and this was actually, and the serum beta HCG was more than 18,000, and this was actually avium. This was a molar pregnancy, and the 22 years old primary, you need to have conserve the uterus for future pregnancies. You cannot do the hysterectomy, and this is the story where this is a big avium which is seen there, and the myometrial vessels are also invaded by this, and so all this thing can be seen and picked up on ultrasound. Again, this is a case, very interesting case. Patient had pregnancy, first trimester, then she, without Consultation with doctor, she took some MTP pill. She had bleeding, but the bleeding kept on going. He went to the doctor. Some doctors, they did a DNC. And after DNC, she had a shock. And once she had a shock, she came to us. And then I found a uterine perforation. And how you find a uterine perforation, you can see this is the uterus. And you can see the air in the myometrium. On 2D, the air in the myometrium, this is the collection air, and this is the collection, and this is the 3D where you can see air in the myometrium, and this is the site of perforation. So uterine perforation picked up on this, patient was managed accordingly, surgical repair was done, and the patient improved. Again, this is a very old slide, I think more than 30 years old slide, but still I love it. Patient went for some MTP, had perforation, and then collapse. And this is what? This is a foreign body. It's a stick. Somebody tried to put the stick in the uterus to get the abortion done, perforated the uterus, and this stick perforated the uterus, came to the right iliac fossa. And this is a big stick which is seen picked up on ultrasound. After that, coming to that first trimester complications, this a case where you can see the fetus is there, patient had bleeding, acute pain, and there is a separation of the placenta. There is complete separation of the placenta, which is seen there in a subchorionic bleed, heavy bleeding. We could not save this baby, and the patient went into inevitable abortion. Again, we can see placenta previa complete there, and there is a big subchorionic bleed, which is seen there, a big hematoma, which is seen there in APH. Patient had pain, bleeding, ultimately again hemorrhage, which is seen there. We could not save this, and again patient had to be, the pregnancy had to be terminated to save the life of the mother. Thus, this is the first trimester complications. The ultrasound role also comes in the second trimester of emergencies. What we can see, the placental hemorrhage, placental mass, cervical incompetence, fibroid degenerations, ruptured uterus, twisted ovarian, and here what we can see here, this is a case where patient kept gasping with a bloated abdomen and acute pain. When we did ultrasound, we found a huge mass in the uterus. It is coming out from placenta. Fresh blood, which is layering sign, was positive. Fresh blood was, and the fetus was crammed to the one side. And this is a huge placental hemorrhage, which is retroplacental hematoma with a placental hemorrhage. Pushing the fetus, we could not save this baby. Ultimately, the hysterectomy had to be done to save the life of the mother. Again, this is here. A patient came with a history of pain in second trimester, abnormal shaped uterus in the belly, and when he did ultrasound, we found a huge cyst in the cyst is coming out from, this is the placenta, this is the 3D, and the cyst is coming out from placenta, and the baby or the fetus is pushed to the one corner. This is the huge cyst which is seen there. This is the part of the placenta from where it is. We trained this under ultrasound guidance, managed the cyst, drained it, and allow decompression was done, and the pregnancy was continued to the full term. This patient herself is a doctor, came with the history of acute pain, and she even did not allow to touch the belly. She was in so much of pain. When I did ultrasound, I found a baby which is around 18 weeks, but there is a fibroid on the anterior wall, and there is a red degeneration of the fibroid. It was a twisted red degeneration of the fibroid which was seen there, and she was in acute pains in the second trimester of the pregnancy. So these are the things. Rupture of the uterus. You can see here, this is the scar rupture in the early second trimester. Again, you can see this is the site of the rupture, and this is the fresh blood. This is the fresh blood which is coming out. I already told you fresh blood on ultrasound is always bright echogenic. So this is the rupture of the scar which is seen there here beautifully in the second trimester. Not only that, you can see rupture of the uterus in this patient, had an acute pain, collapse, came in shock. Then this is the uterus, and there is a rupture from here, and the fetus came to the right iliac fossa. It is lying, this is the endomit cavity. Here is the rupture from here coming, and the fetus was lying seen in the right iliac fossa, and this is rupture of the uterus seen in the second trimester. Again, this is a very old slide, but still I love it because you can see about 30 years old slide where the right pregnancy, abdominal pregnancy growing in the abdomen. And here you can see this is the uterus, this is the fetus, and this is the placenta which is seen there. This is the uterus. This is the uterus, this is the fetus, this is the placenta. You can see again, this is the uterus which is seen there, and the fetus is seen in the right iliac fossa in the abdominal pregnancy. The uterus is absolutely fine. So these are the abdominal pregnancies. Patient presented with pain and picked up on ultrasound. This is a very interesting case. Clinically, it suspected the case of rupture uterus in a pregnancy, second trimester pregnancy. Patient came in acute pain. When I did ultrasound, I found the uterus was pushed to the one side, right side, and the baby was absolutely fine. It was there. The uterus is something which is seen to the pushed to the right side. There is no evidence of rupture of the uterus, but there is a mass which is seen on the left side of the abdomen and adjacent to the uterus, pushing to the uterus. I could not make it what it could be, but I told the clinician, see, look, this is not rupture uterus. Baby is absolutely fine, but I found a mass over there. This is the peroperative finding. It was a ruptured, twisted, huge ovarian cyst. And this was taken care of, taken out. This is the placenta, this is the mass, and the baby, the pregnancy was allowed to continue. Second trimester, cervical incompetence. This a patient who had a recurrent abortions. This is the case of cervical. How ultrasound can pick up? You can see opening of the endocervical canal. This is the cervix which is seen there. You can see here the lymph foot. This is again opening of the cervical internal os. Here on AVI, you can see the footlings are seen bulging out from there. And again, you can see on AVI how beautiful say it's a cervical incompetence. So immediately I told this is a case of cervical incompetence. The footlings are bulging out from the internal os, and the patient was taken to the OT for the putting the cerclage, and the pregnancy was allowed to continue. So all this thing we can see on ultrasound beautifully and managed. Then we come to the third trimester pregnancy, and this was a case of a placenta abruptio. Patient came in acute shock, third trimester pregnancy, and this is a complete separation of the placenta which is seen there with a big hematoma formation, retroplacental bleed. The baby was live, you can see, but unfortunately we could not save this baby. Coming to this placenta creta, it is very, very important. We have got now in high incidence of placenta, morbid adherent placenta because of the high rate of cesarean sections. The result due to the absence of they are different classification, but I am just going to show how we can diagnose. Accreta, where it adheres with no muscle invasion, increta invades the muscles, and percreta when it invades the uterus and adjacent structure. So previous C-sections, placenta previa, complications, antepartum rupture of the uterus, and this is the morbid adherent placenta on the grayscale imaging. Large placenta, inhomogeneous structures, loss of homogeneous uteromyometrial interface. You can see placenta-uter interface, hypoechoic pockets in the placenta, and this here you can see. This is the placenta percreta. The patient came with a history of pain with hematuria. This is the urinary bladder, this is the Foley's bulb, and this is the placenta, which is seen invading the urinary bladder wall. And this is the urinary bladder wall, and multiple vessels which are seen coming out from the placenta and then invading the urinary bladder. And this is the hysterectomy was done. Not only that, partial cystectomy was also done to save the life of the mother. So how we can diagnose, this is very important, and what clinician you can guide the clinician. So this is the case of placenta percreta, and with partial cystectomy it was done. Again, we can see the placenta accreta. This is the grayscale imaging. These are the fetus, multiple vessels and scenes invading the myometrium. You can see here, and then invading the color Doppler. You can see so many vessels which are seen invading the myometrium. 2-0. I have seen only 3 cases till date of the 2-0. There are unexplained death, fetal death in the late trimester. This is very, very unfortunate. And this is the case of 2-0, umbilical cord knot, which you can see here. This is an emergency. Here you can see this is the 2D, and this is this color Doppler. This is the cord, and this is the true knot. This is the true knot which is going there. How you can suspect it? Because particularly persistently I'm seeing the knot by tapping the baby, moving the baby. I could not untie it, and then this is a true knot which is seen there, and this is a real dangerous situation. Cord hematoma, they are not that common, but they may be iatrogenic. Cordycentesis, trauma, high incidence of perinatal mortality is seen, and this was the case of cord hematoma which is seen here. This is the cord. On Doppler you can see the vessels are compressed. There is no flow in the hematoma here, which you can see. So this is very, very important to understand. Coming to the vasa previa, this is also very, very important situation and requires emergency management. The fetal blood vessels run cross over the external uterine orifice. They are unsupported and freely hanging when supporting membrane rupture, as vessels are unsupported by umbilical cord or the placenta. And here is the case. These are the vessels which are seen there, and this is the specimen. You can see the vasa previa, where you can see unsupported membranes which are seen, multiple freely hanging vessels which are seen there. This is very, very important to understand, because these vessels, once they rupture, they will lead to the fetal death. So coming to the third trimester, Doppler. It is when you have to guide the clinician, take it out, this is emergency, otherwise baby is going to die. When you find the umbilical artery reversal of flow, deep A notch, and pulsatile flow in IVC, it means the baby is grossly compromised. The Doppler is greatly damaged. This is a very interesting case. A lady who lost her 3 babies because of the early onset of hypertension. And third baby, she again came hypertensive, blood pressure was not controlled, 26 weeks, 500 grams baby, umbilical artery reversal of flow. You can see uterine artery persistent notching, marked brain spinning effect, and DV reversal. And you can see the heart is though enlarged, but it is okay. On DV reversal of umbilical artery, high resistance flow, we immediately guide the clinician to take out the baby. And then on fetal HQ, if you see that the shape of the heart is almost normal, if you see the left ventricle does not show any strain, but right ventricle shows bulging out, means there is some, this is the area of the right ventricle, so there is a strain on the right ventricle. If you see the fractional contractility, it is left side is okay, but right side there is some strain which is seen there, and on fractional straining it is normal. So what I mean to say, the heart, the baby is so grossly compromised, but heart was not that bad on fetal HQ, and the baby was taken out with 700 grams. The baby was for 3 weeks in ICU, and the baby survived. So this is how fetal HQ is very helpful. This is the case which I did yesterday only. A lady of APLA syndrome lost two babies before, had one child. Yesterday she again came, and at 28 weeks with 2 weeks IUGR, what I found, the umbilical artery reversal of the flow. Can you see here? And high resistance flow seen in fetal aorta. You can see there. The PI was 2.62 in fetal aorta. Deep A notch seen in DV, but there is no reversal of flow. And on fetal HQ, if you see that the left ventricle having the out bulging, the size become large because high resistance flow in fetal aorta because of the coagulopathy. You can see here there is a strain seen in the lower part of the base of the right ventricle. But if you see here, this is going out left ventricle. So this is on fractional shortening. You can see here what this is. The baby was operated yesterday night itself. 1000 gram baby was taken out, and baby is in ICU. The mother. So what I mean to say, Doppler and fetal HQ, left ventricular dilated globular shape, left ventricular restraint because of high resistance flow in fetal aorta. All these, and APLA positive, 2 lost babies, 1 survived, another days, 28 weeks, 2 weeks, 1000 grams, baby in ICU. Hopefully the baby will come out well. Again, if you see fetal hypoxia, fetus in CHF, dilated fetal heart, size of the heart is more than 1/3 of the thoracic diameter, high resistance flow in umbilical uterine artery, umbilical artery reversal of the flow, pulsatile flow seen in IVC. Not only that, there is a pericardial effusion and the heart, the baby in CHF. You can see the pleural effusion, little ascites, fetus in CHF, and this is again the Doppler which is deranged. So immediately means baby is severely compromised, and the clinician was asked to take out the baby, and the baby was taken out. The baby had to be in ICU and ICU for a long time because of the compromised heart. So these are the situations where ultrasound Doppler in third trimester can guide you when to take out the baby, whether it's immediately take out the baby is going to die. So these are the roles of ultrasound in different trimester in obstetrical emergency, starting from first trimester, where the bulk is ectopic pregnancy, but also there is other things like APH, like abortions or vesicular molar pregnancy and other things. Second trimester, rupture of the uterus, cervical incompetence, abdominal pregnancies, morbid adherent placentas. Third trimester, yes, it is growth, it is Doppler, it is fetal HQ, where you can having the parameters and details in your hand to guide the clinician to take out the baby immediately. Thank you very much for your patient hearing, and I think with my experience, what I shared with you about the role of ultrasound in obstetrical emergencies. It is the tool which is non-invasive, easy to do, without any preparation, and can be done in any emergency situation. Thank you very much.
Thank you very much, sir. The talk is very informative, and I must say the cases you have shown are very unique, and I hope that all the audience must have got gains from your talk, today's talk. We have got huge response in the form of questions, sir. So now I will read out the questions to you for the question answer sessions. Yeah. So the first question is, sir, what is the significance of abruptio placenta in third trimester twins?
You see, it is a very tricky situation. It depends. If it is a monochorionic twins, then it is very, very difficult situation. You try to understand because one placenta is there, and if there is an abruption, I don't know how to deal with. It's a very difficult situation for the clinician. But if it's a dichorionic placenta, it's a two placenta are there and one got abruption, the baby which is got the abruption, that is at very risk. It all depends immediately what is the weight of the baby to take the baby out, and second baby, if it is fine, at least there is a chance of having one baby. But monochorionic, it is very, very difficult to say. Abruption. So it all depends how much is the abruption, how much is the hematoma formation, what is the surveillance says, what that is, it depends how much is the separation. If it's a total abruption, it is very difficult to save the babies.
Thank you, sir. The next question is, what is the sensitivity of ultrasound in diagnosis ectopic pregnancy?
You see, yes, it's very important question and very important to understand that ultrasound is not 100%. That is one thing one has to understand. There is 12 to 15% chance of missing ectopic in expert hands. That's the biochemical screening and collaboration with bio. If serum beta SCG is 2000, the TVS must see the gestational sac on ultrasound. If you fail to see that, you look for the other thing, anywhere ectopic. You see, patient, as I told you, 50% ectopics are asymptomatic. So you may not get the clinical sign, but if your serum beta SCG is more than 2000, you fail to see the gestational sac, you again call the lady, again see, try to look for the things. Because many times the adnexa are not clearly seen on TVS also. Bowels with the, so you have to look for the, but still there is about 12 to 15% you can miss on ultrasound. Particularly when the sac is overlapped or tube is overlapped by adherent bowel loops. That is very one thing. So you have to look for the correlate with serum beta SCG and see the things and again call, and again I have seen that I miss ectopic in first go, but I was suspecting it because the beta SCG was high. Again I called and after 2 days I picked up the ectopic. So that happens. You always guard the clinician, look, I am not going to see, but with your beta SCG, I need to see the patient again.
Okay. The next question is how to differentiate between scar ectopic and scar rupture.
You see, I have shown you the scar ectopic and scar rupture. There I have shown you the cases. You see, scar ectopic, grade 4 grades on ultrasound. You need to see a gestational sac on a scar in grade 1 where it is 50% of the myometrium. In grade 2, it is more than 50% of the myometrium and you will see an embryo. In grade 3, it will bulge out, but you will still see the embryo. Not rupture is there. And grade 4, there is a rupture and you will see a mass, corpus. So this is very important to understand. In scar rupture, not associated with scar pregnancy, you will see, I have shown you the case where you will see only the site of the scar and there is a discontinuity or there is a rupture. If you have the TVS, you can see, but transabdominal with inadequately filled bladder, you can see the bulging and you can see the rupture. So there are two issues: scar pregnancy with rupture, scar rupture with intrauterine pregnancy. They are the two different issues. You got my point?
Okay, sir. The next question is, can ectopic pregnancy be seen in the broad ligament?
You see, ectopic can happen anywhere. You can see it, but it is difficult to say it is a broad ligament. 95 to 97 pregnancy, they happen in tube. I've shown you that. Only 3 to 4% pregnancies are beside the tube. Abdominal pregnancy, if there, that is different. But you have to have a wide sweep probe, but it is difficult to say it's a broad ligament pregnancy. Same way, ovarian pregnancy, it is difficult to say it's an ovarian pregnancy because it looks like a mass. The same way, the ligament pregnancy, it looks like a mass. So categorically, you cannot say it's a broad ligament pregnancy.
Okay, so the next question is, what is the minimum thickness of myometrium in cornual pregnancy? How to measure it and in which plane?
You see, minimal thickness, I have shown you that it's a 5 millimeter minimum thickness. And myometrial, for that you have to have the coronal section. Coronal plane, the 2D plane, you will not measure it. In the coronal plane, you will have the whole uterus in the coronal section. So minimum 5 millimeter thickness, you can, a rim of myometrium you should have for that around the gestational sac, which you can measure. And myometrium sac is echogenic, myometrium is hypoechoic. So you can differentiate it. So minimum 5 millimeter thickness, and that you measure in coronal plane in vertical axis, not long axis. In vertical means in vertical axis you measure it.
Okay. The next question is, how one can differentiate between originally cervical pregnancy and intact gestational sac in the face of expulsion?
Cervical pregnancy and in the face of expulsion, if you see that in the face of expulsion, you will see the there is history of bleeding. You get my point, number one. Cervical pregnancy also you can see in the face of expulsion. So you can see the opening of the internal os in the face of expulsion. If you see that opening of the internal os, it means this pregnancy is going to be expelled. So you have to see the, I've shown you, as I've shown in the cervical incompetence, I've shown you the video clip, how the internal os is opening up. So you have to be seen persistently where there is an opening of internal os is there or not. If the opening of the internal, in the phase of expulsion, there is a opening of the os and the cervical pregnancy. You have to see that. Or today you see it, next day again you call the patient in the phase of expulsion. It is not necessary always that you will see in the same sitting the process of expulsion.
The next question is, how to diagnose red degeneration versus normal fibroid?
You see, red degeneration is an acute condition. You try to understand. Normal fibroid you will not see. It's a histopathological condition. But if there is an acute pain and there is a twist, and then you will see area of necrosis in red degeneration. In normal fibroid, you will not see the area of necrosis. You will not see the area of necrosis. Normal fibroids, they are by and large mixed echogenicities or homogeneous, or may show calcification or may capsule. In red digestion, you will see a capsule, but a central area of necrosis is also there and acute pain.
Okay. The next question is, sir, can you suggest allowing of abdominal ectopic pregnancy if it is a precious pregnancy for parents age-wise?
It is very it is, I don't know, I can give you the answer. It depends. There are reports that few abdominal pregnancy went up to late or mid third trimester, but I don't know. It is not my domain, so I am not expert on that, frankly speaking. It depends on many conditions, how the lady is doing, or how because you never know when the problem comes up in abdominal pregnancy. So I am not expert on that, but it all depends, treating physician, clinician, on all those. I don't know. My wife can give you the better answer. Yes, I just want to thank my wife, Dr. Yashoda. She is Professor OBGYN and head of the department. In preparing this talk, she gave me so many important clues about role of ultrasound in obstetrical emergencies. It is really her inputs, her clues, her insight was very, very important for me to make this talk.
Sir, the question, next question is, how common is placenta accreta with an mid-upper segment anterior placenta?
Mid-anterior segment, anterior placenta. You see that
Yes,
it
sir.
is not that common. More common is the lower uterine segment, placenta accreta. Because you see, you need to have a irregular surface of the myometrium. You got my point? And for adherent placenta, and that there is a scar, there is cesarean section, and there is a fibrosis, so there is more chance of getting it adhered at the lower part or low-lying placenta. But still, if it is a wide, there is a repeated cesarean. We get patients where the 3 cesarean were done, or 2 cesarean are very common, or third. Then in those cases, you will get the wide area of adherence, morbid adherent placenta. So history of the patient, number of the C-sections, repeated uterine interventions, multiple MTPs. You always talk to the patient. Multiple MTPs, uterine infections, history of long uterine pelvic infections. So that all these conditions may lead to the wide area of adherence of placenta.
Okay, so the last question is, the role of beta HCG discriminatory zone in early twin pregnancy.
You see, role of beta early twin pregnancy means what the doctor wants to know.
So that's the questions written.
Mm-hmm. That I don't know actually. I'm not expert of that. Early twin pregnancy, role of discriminatory zone, that I don't know. Because if it is a delayed twin pregnancies, then there's a different issue. But I am not expert on that.
Okay, sir. Thank you very much. These are all the questions were there. Thanks, audience, to join in today for these lectures. Thank you very much, sir.
Thank you.